Good evening, everyone, for those who are joining from India, and hello to others who have joined us from other parts of the world, which I think many people are there. And good morning to Professor Julian Sosa. A very warm welcome to all participants joining us. And today marks an important milestone for endocrine community as we stand at the cusp of major paradigm changes in thyroid cancer management shaped by 88 2025 guidelines. We have gathered here with one shared mission to reimagine what modern evidence-based thyroid cancer care should look like. This webinar is being conducted in collaboration with the Indian Association of Endocrine Surgeons and the Breast and Endocrine Society International, and I thank both societies for their continued commitment to academic growth. With that spirit, it is my privilege to introduce today's keynote speaker, a legend in endocrine surgery and a global voice shaping the future of thyroid cancer care. Professor Julie Ann Sosa needs no introduction in the endocrine world, but she certainly deserves one. Professor Sosa is the chair of surgery at the University of California, San Francisco, one of the most influential positions in American academic surgery. She is globally recognized as a surgeon scientist whose work has fundamentally shaped how we diagnose, manage, and understand differentiated thyroid cancer. She is known for her prolific scientific leadership, authority on guidelines, a physician scientist shaping global discourse, a mentor and a role model. Professor Sosa is known for her leadership in training, diversity, global surgery, and data driven policy making. She has mentored countless endocrine surgeons and researchers and clinician scientists, including many from Asia. And today, we are fortunate to hear directly from her. She will speak on a topic that every endocrine surgeon is eagerly watching: 88 2025 Paradigm Shifts in Thyroid Cancer Care. Professor Sosha, it is truly an honor for the endocrine community of India to learn from you. So, ladies and gentlemen, please join me in welcoming Professor Julie and Sosa. And floor is all yours now, Professor Sosa.
Oh my gosh, thank you so much. My mom would be so proud of that introduction. Yeah, thank you. And the honor and privilege is all mine. It's 6:30 in the morning here in San Francisco, California. I am not flying above the Golden Gate Bridge, but the sun is not risen, but I have my coffee.
Great.
And I really, what I'm trying to say is that it is an incredible privilege to join colleagues from around the world to talk about, I think, our collective passion, which is serving patients with thyroid cancer by doing the right thing based on evidence. And so today I'm going to kick things off, debate, discussion, maybe even some disagreement, which I welcome. It is good to review evidence and discuss how best to interpret that evidence. And after I present, I'm going to look forward to listening to how others think about that evidence and potentially apply or differently apply these guidelines in the Indian setting. So let's get started. A lot of people say, Julianne, why do you have a seismograph on your first slide? First of all, I'm from San Francisco, so we frequently have tremblers and earthquakes. But really, I have this seismograph because I do think these guidelines imply that there will be potentially some significant changes coming in how best to manage patients with differentiated thyroid cancer, and that'll be the focus of what we talk about today. These are my disclosures, and they don't really pertain to the content of this talk. So some of you may recognize the image on the left. That is the cover of the August issue of the journal Thyroid. This is figure 2 from the guidelines. And I do think figure 2 will probably be the most used image from these guidelines, in that it provides the new estimated risk of structural recurrence that I think will help to guide how we think about and treat patients going forward. And we will be talking about that a little later. Well, a lot of people, when we talk about guidelines, in our case, the American Thyroid Association guidelines for the management of adult patients with differentiated thyroid cancer, they dive right into the 84 recommendations and the 1,458 references. But I always say, let's pause first and just review who wrote the guidelines. And the reason I say that is all of us have implicit bias. And I think understanding what potential bias the authors have will help us to understand the conclusions that they reach. So I am one of the co-chairs of the committee, along with Dr. Matthew Ringel from The Ohio State University. He is an endocrinologist in the United States. Not surprisingly, the guidelines are international, very, very important. And they include endocrinologists, surgeons, both endocrine surgeons and otolaryngologists, and pathologists. But this year, we have adapted to some deficiencies from prior guidelines. We've added through 3 nuclear medicine physicians, really essential. We've added a genetics counselor. We've added a medical oncologist, given the dynamic around small molecule therapies. For so long, too long, we did not have the patient voice represented. So we have Gary Bloom from P.I.N.K International. And finally, we added a methodologist. Why? Because there is a deficiency in a lot of the science that serves as the underpinning for these guidelines. And we actually did primary science to support the new guidelines and some of those deficiencies. Another new part of these guidelines is what we call the data framework. There's nothing non-intuitive about the data framework. The data framework follows the patient journey through their cancer care, and it's what we do each and every day in our clinics. Importantly, compared to the 2015 American Thyroid Association guidelines, we have pulled out thyroid nodules. They will appear in a separate set of guidelines that will be published in 2026. So in these guidelines, the patient begins their journey with a diagnosis of thyroid cancer, typically a cytologic diagnosis. The patient then moves to the first A, an assessment of risk and benefit based on biochemical testing, imaging, transdisciplinary discussion at tumor board, etc. The patient then moves to T, treatment. Now, traditionally, this has meant surgery, and it still means a lot of surgery, but in this iteration of the guidelines, we're going to give some alternatives to surgery potentially at some junctures, including active surveillance and percutaneous ablation technologies. And then the second A, which is really a reassessment of the patient after the initial treatment intervention, to see if they need adjuvant treatment or how best to monitor the patient. And then, of course, the patient can recycle through the data framework. Why? Because differentiated thyroid cancer is an indolent disease. Fortunately, only rarely do patients succumb to it. Well, let's take these guidelines, which can be a little remote and ambiguous, and apply them directly to a case. And I wanted to use a case that's a common scenario. A 33-year-old woman who walks into your clinic with a neck mass. She's asymptomatic and euthyroid. Of course, she undergoes a dedicated neck ultrasound, which continues to be the foundation of imaging for thyroid cancer. And she has 2 nodules. On the left side, a 2.5 centimeter nodule. It is palpable. It's what brought her to medical attention, but it's spongiform, so almost certainly benign. More concerning in the right lobe is a 1 centimeter nodule with calcifications, irregular borders. It is hypervascular. No pathologic lymphadenopathy is seen, and FNA is performed of the smaller nodule, and this reveals a papillary thyroid cancer. So in 2015, in prior iteration of the guidelines, and I think what most of us around the world are doing today is surgery. And typically, if the patient does not have contralateral pathology, either suspicious nodules, large nodules, documented cancer, a history of radiation, a family history of non-medullary thyroid cancer, we would offer the patient a thyroid lobectomy. Well, that continues to be at the epicenter of what we would recommend at this stage. But in recommendation 11, we are now providing 2 alternative treatment strategies. The first is active surveillance. Active surveillance may be offered as an appropriate management option, not for all patients, some patients. And shared clinical decision-making, a theme of these guidelines, meaning it is important that patients understand the risks and benefits of different strategies. They talk together with their clinical team and then levy a decision that is unique to them and personalized. So that's shared clinical decision making is deployed to weigh these risks and benefits. That's a conditional recommendation based on low certainty evidence. Another alternative is ultrasound-guided percutaneous ablation. As an alternative, again, shared clinical decision-making needs to be deployed. Now, you could say, and many have asked me, Dr. Sosa, are you talking about radiofrequency ablation? I might be. We are agnostic to the technique used for percutaneous ablation. I think a lot of that depends on the unique institutional milieu and the expertise that you and your colleagues have. It could be RFA, it could be cryo, laser, ethanol ablation. But I think overall it is an alternative for papillary thyroid microcarcinomas less than or equal to 1 centimeter in size. Well, many believe the more controversial recommendation is active surveillance. And a lot of people have said, Julianne, how could you possibly know a patient has thyroid cancer and leave it in and not take it out? Well, a subgroup of our guidelines task force in 2022 in the journal Thyroid did a systematic review, meta-analysis shown here, comparing active surveillance to upfront surgery. We reviewed the experiences of more than 75,000 patients, primarily with papillary thyroid carcinomas less than or equal to 1 centimeter, who alternatively had active surveillance or upfront surgery. Okay. Overall, low risk of all-cause and cancer-specific mortality, low rates of distant metastasis, low rates of clinical recurrence, regardless of which strategy was taken. Among the active surveillance group, the rates of tumor growth were very low. And when patients crossed over to surgery from active surveillance, they almost always did so because they either were unable or unwilling to continue to comply with active surveillance due to anxiety. Overall, though, there needs to be more studies in this area. Well, then the next question becomes, let's say we accept that active surveillance may be an alternative strategy for some patients. How should we do that? In recommendation 12, we explain that neck ultrasound should be used to monitor patients undergoing active surveillance for disease progression. That's a good practice statement. Well, a lot of people ask me to stop and they say, where's the thyroglobulin levels? Where's the anti-thyroglobulin antibody levels? We looked at that literature and we believe that the routine management of serum thyroglobulin and or anti-thyroglobulin antibodies is not recommended because it is unreliable. And I'll talk more about this in a few minutes. That's a conditional recommendation based on very low quality evidence. Well, a lot of people, again, have paused and said, It sounds like you're a little prescriptive, Julianne. Are you sort of trying to tell people what to do, whether it's clinicians or surgeons? And on the contrary, we are not. We believe in shared clinical decision making, and we also try to provide some guidelines about if you're going to do active surveillance, how to cross patients over and when. It's when they develop new biopsy-proven lymph node metastases, when their primary tumor grows by 3 millimeters or more. That's a magical number. You're going to see it reappear in the thyroid nodule guidelines in 2026. If they develop distant metastases, evidence of extrathyroidal extension, posterior growth to the aerodigestive tract, or the most common scenario when the patient becomes very anxious. That's a good practice statement and what drives most of the crossover. Well, in the case of our patient, indeed, her nodule did grow over 2 years. It grew to 1.3 centimeters. As a result, she became anxious and she wanted surgery. So the question is, how do you then prepare patients for surgery? Well, one of the frequent considerations is how to best to deploy cross-sectional imaging. It should not be deployed for the patient we are talking about. Rather, in recommendation 8, we explain it should be deployed for patients with advanced disease. So, large primary tumors, bulky lymphadenopathy that jeopardize neurovascular structures or the aerodigestive tract. When the tumor advances posteriorly, retropharyngeally, or substernally. That's a strong recommendation based on moderate certainty evidence. I deploy IV contrast CT as my preferred adjunct cross-sectional imaging. Well, she now has a 1.3 centimeter tumor. What operation should we do? Well, in 2015, you will recall, we said you could do a lobectomy or you could do a total thyroidectomy. They both would provide equivalent long-term outcome. We've now taken low-risk differentiated thyroid cancers and divided them into 2 groups, those 1 to 2 centimeters in size and 2 to 4 centimeters in size. Remember, none of them should have extrathyroidal extension or metastatic disease. For those patients with tumors less than or equal to 2 centimeters, so our patient, we are now saying that the initial surgical procedure should be a thyroid lobectomy unless there is cause to remove the contralateral lobe. That's a strong recommendation based on moderate certainty evidence. Not our patient, but say a patient with a larger tumor, 2 to 4 centimeters in size, still low risk. We say that thyroid lobectomy may be the preferred initial surgical treatment. So a weaker recommendation than those with tumors 1 to 2 centimeters, but still preference given to lobectomy. It's a conditional recommendation based on low to moderate certainty evidence. Why? Equivalent outcomes long-term to total thyroidectomy, but superior short-term outcomes compared to total thyroidectomy. Not our patient, but let's say you now have a patient with an intermediate or high-risk tumor, over 4 centimeters in size, extrathyroidal extension, local regional metastatic disease, no change much here. The initial surgical procedure should be a total thyroidectomy with gross removal of primary tumor and block resection of muscle, compartmental lymph node dissection, and that continues to be a strong recommendation. Well, what about the eternally controversial topic of prophylactic central lymph node dissection? I think we all should agree that a therapeutic lymph node dissection should be performed if you have radiographic or clinical evidence of metastatic disease. But what about prophylactic lymph node dissection where you do not have either of those things? We are saying that prophylactic central lymph node dissection should not be performed for most small, non-invasive, clinically node negative PTCs. So those are AJCC, CT1, T2, C, and zeros. And for most follicular thyroid cancers, they obviously spread hematogenously, a strong recommendation. Well, surgeons are on this webinar, so you're probably saying, what about the nerves? How are we going to examine them or not examine them in the operating room when we do a thyroidectomy? Some changes here. So we continue to recommend try to visually identify the nerve and track it in the neck under direct visualization. But we are beginning to move towards doing more intraoperative nerve monitoring in an effort to improve accurate nerve identification and improve voice outcomes. The data are actually superior for the protection of the external branch of the superior laryngeal nerve described in recommendation 23C. That's a conditional rec based on moderate to high certainty evidence. For the RLN, the recurrent laryngeal nerve, also a conditional recommendation, but only low to moderate certainty evidence. And then unchanged from 2015, before you go to the second side, somehow you must assure the integrity of the first nerve to avoid a bilateral recurrent laryngeal nerve injury. Well, in the case of our patient, she didn't want a lobectomy. She had that contralateral nodule. We told her it's probably benign. We could follow it. We could FNA it to assure her. She said, no, I want my whole thyroid out, and that is what we did. In the end, she had a 1.6 centimeter classic PTC, 1 of 5 lymph nodes removed, had a micrometastasis without extranodal extension. So what is her stage? She has an AJCC-UICC stage 1 tumor with excellent anticipated long-term survival, and she is a low-risk ATA category. So here's figure 2, and I think figure 2 is the figure that most clinicians are probably going to put in their back pocket to help them guide discussions in clinic. It's similar to the one in 2015, but has changed in 3 critical ways. 1, there's a lot more color and it's prettier, but 2, we've divided differentiated thyroid cancer into each of its histologic subtypes. So PTC, follicular thyroid cancer, oncocytic thyroid cancer, and you have separate risk stratifications for each histologic subtype. And then also we have taken the intermediate risk group, a controversial group of patients as to how much surgery should we do, should we give radioactive iodine, and we've divided it into an intermediate high risk group and a low to intermediate risk group. Of course, neither of those groups are our patient. She is a low risk group with a recurrence risk of less than 10%. So should we give I-131? I hope we all agree, absolutely not. Well, now it's time to reassess the patient. So to reassess, you must collect data. You will see we collect data at 6 weeks and 6 months. Her TSH, not suppressed. It should not be suppressed for a low-risk tumor, but her thyroglobulin level is 0.8. In 2015, that would be a little worrisome. Fortunately, her neck ultrasound is reassuring. So the question is, what do you do with these kind of indeterminate thyroglobulin levels? Well, back to my remarks at the beginning. I think the use of thyroglobulin in the postoperative setting should evolve. This is a systematic review meta-analysis published in 2022 by a subset of our guidelines writing group. What we found when we looked at thyroglobulin levels and antithyroglobulin antibody levels is that after thyroid lobectomy, there is no threshold that we could identify to define remission. In patients who undergo total thyroidectomy without radioactive iodine, again, we could not find a threshold to accurately predict residual or recurrent disease. Only after total thyroidectomy with radioactive iodine was thyroglobulin and thyroglobulin antibody levels reliable. In the setting of total thyroidectomy without I-131, the best we could do was to come up with this range of 1 to 2.5 or less with a normal TSH as potentially being a threshold range for predicting residual or recurrent disease. So table 9 is brand new. It looks at response to therapy after 3 scenarios: total thyroidectomy with I-131, total thyroidectomy without I-131, and thyroid lobectomy. As you see, moving from left to right, you go from a lot of granularity with thyroglobulin levels to just that threshold range. And then after thyroid lobectomy, really thyroglobulin levels are not useful. We recommend getting 1 immediately after surgery because if it is off scale, then something is worrisome and you've clearly missed something. Where's our patient? Right here in the middle, post-total thyroidectomy without radioactive iodine. So the question is, How long do you nowadays have to follow this patient? Well, her thyroid globulin levels remained low over 5 years. She had ultrasounds that were reassuring at 1, 3, and 5 years. So she has a continued excellent response. And we are now using the term complete remission. This is borrowed from surgical oncology, radiation oncology, medical oncology. So we're becoming more mainstream in endocrine oncology. Can we ever say goodbye to this patient? So she was at low risk to begin with after surgery, a less than 10% risk of recurrence. Her treatment response over 5 years is durable and sustained, and she finishes with a new dynamic risk assessment of low with a less than 2% risk of recurrence at 5 years. So a brand new table, table 11, which says that for patients with low risk tumors who have a durable, excellent response to therapy, we can actually discontinue monitoring unless their thyroid globulin level rises or their antibody levels become newly detectable. I'll tell you honestly, in my clinic in San Francisco, I have patients who I've been following for 40 years in the clinic. Is that right? We don't think so. So where do I want to finish and get you guys started debating, discussing, and arguing? Well, I think the person who got it most right is this dude. He's a very famous American architect, not a surgeon, not an endocrinologist or physician, Frank Lloyd Wright. And he said, less is more only when more is too much. And what I think we should plan for is the idea of personalized therapy. I think we need to listen to patients about what their preferences and values are. I think we need to better understand the mutational and biologic profile of the disease because I think it varies across patients. I think we need to put patients at the epicenter of our decision making and share that decision making with patients. And finally, I don't know, guys, I hate change, but I think change is coming to thyroid cancer care. And I think we should embrace change if it is supported by evidence. On behalf of my colleagues, thank you so much for the privilege of talking to you today.
Thank you so much, Professor Sosa. As always, your talk was like a lighthouse, precise, bright, and guiding all of us towards better patient care. I think we can take a couple of questions here, but after your talk, I am convinced that ATA should add one more recommendation that preferably guidelines must be explained by Professor Julie and Sosa.
You are too kind.
So, anyone has
I have
any?
a question. I have three questions, in fact. Very nice presentation, Professor Sosa. So, what I would like to ask is, do you really think estimation of preoperative thyroglobulin in any way is useful? Because in the subscript of your recommendation for preoperative thyroglobulin, it says a study that mentions 50, 30, and 60 for presuming ipsilateral, contralateral, and lateral neck lymph nodes. So, do you think in any way it would benefit us?
Yeah, thank you for that question. There are definitely thought leaders in thyroid oncology who routinely measure one thyroid globulin in the preoperative setting. And if it comes back way, way off scale, it helps to drive more imaging, more testing. I'll be honest with you, the majority of our task force did not think you needed to do that. And the reason is, I think you're going to find those people, particularly the papillary thyroid cancers, because they're almost certainly going to either have very large primary tumors, invasive, locally advanced tumors, or metastatic disease in the neck that sort of gets you looking. And the reason why, in the end, to us, it didn't make a big difference is you're still going to do surgery, right? Like, you still have to, in differentiated thyroid cancer, obviously clear the neck as best you can to facilitate either I-131 therapy or small molecule therapy, right? And I do want to say in the guidelines, I didn't have time to talk about it, but in my own practice and in the guidelines, we're starting to now talk about neoadjuvant therapy, where we use small molecule treatments, like in people with sky high thyroid globulin levels and cancers that are not going to come out with an R0 or R1 resection. And could a thyroid globulin level help you there? Yeah, but see, we finish with, are we going to do anything different? Are we still not going to do the operation? And I think it makes a difference in medullary to get the calcitonin and your CEA, but not so much with DTC.
Not right now, at least. And another mention about the ablation procedures that you have included, um, because ATA is widely followed. And if you mention ablation in the guidelines, it's going to pick up, you have specifically mentioned it for microcarcinomas, but I'm sure people don't read that clearly, and they would extensively use microablation. So, what is your thought on using ablation for these tumors? Because the evidence that you have given there is also, there are two meta-analyses that you have mentioned, which have largely retrospective studies, and we are not there yet to recommend ablation for carcinomas.
Yeah, so thank you for that question. And I think you highlight a really important point, is that while we spend a long time like choosing our words very carefully, in the end, it's how people interpret and perceive and read or misread guidelines. And I think that by opening the door a crack in very limited settings, papillary thyroid microcarcinomas, as you say, less than 1 centimeter, or in the remedial surgical setting, I saw a patient last week in clinic who if we operated on this lymph node she had in her neck, it would be her 8th operation for papillary thyroid cancer. And I was like, I don't know, I've done a lot of this surgery, but I think there's a good chance you could have a complication here. In that setting, we say percutaneous ablative technologies could be used. But could people misinterpret that and think the door has been opened wide and they can do it? Yeah, I think that is possible, which is why I'm on the circuit trying to be very precise. In my own practice, I will be very honest with you, and in our practice at UCSF, we have 6 endocrine surgeons. We see several, I don't know, a couple thousand, several thousand patients a year. We are not using ablative technologies. We are not using ablative technologies for cancers. We believe that this is the most dynamic area of science, and but we also feel like the science best supports benign nodule management. So I'm revealing how I felt about this recommendation and what we're doing. We're very cautious at UCSF. But I think in Italy and in Asia, there are emerging and stronger data showing it's good on these fringes. So more to come, keep an open mind, but we in San Francisco are not quite there yet.
Like Dr. Sanjay said, I think when people listen to you, it makes more of an impact.
Yeah.
Since you're specifically categorically again mentioning microcarcinoma. So my last question on nerve monitoring. We don't have evidence saying visual identification is better. We've never done a study, but why are we hesitant in extensively using nerve monitoring? Because probably we are assessing complication rates and not really seeing the speed of the surgery with nerve monitoring there. So are we still hesitant to recommend that as a strong recommendation in the guidelines?
Yeah, so thank you for that question. So again, full reveal, as you get to know me, you will see I try to be a very transparent person about what I believe, and then I listen to people, right, and read the evidence. So in my own practice, I use the nerve monitor for 100% of my cases. And I do that exactly as you said, as to whether it reduces my nerve injury rate. I think so. But what I'm much clearer on is that it makes me a more efficient surgeon, a faster surgeon. And it allows me to prognosticate. So when I come out to talk to the family, I can say with confidence, whether they have a scratchy voice at the beginning, it's going to be fine. We had great signal and waveform. In the United States, it's used by about 60% of surgeons. In Europe, I don't know, in India, it's nearly 100%, right? It's like 99% in Germany. So I do think this is the way of the future. I think the reason why we stop short, in fact, I have gotten a lot of personal flack for this recommendation, but for the opposite reason. There are a lot of our colleagues who are high volume endocrine surgeons who believe that it is unacceptably expensive to use this. And they say this, for instance, in the United States, which it's profligate here. Like people throw money all over the place. And so insurance companies and other eyes are on this. So we actually, the truth of the matter is we had a slightly stronger recommendation, and I had some threats on my life along with the other surgeons on the committee. That's an exaggeration, but people were really questioning it. I honestly will tell you, I think in the next iteration of the guidelines, this will become stronger. It may not in the field of benign thyroid pathology, but in cancer, I think the data are there, and you will see these guidelines are much stronger than those in 2015. So we're moving the ball. We are doing it in a way that everyone can find palatable, but to a finish line that is correct, I believe, and that is for the reasons you said: prognosis, effect, efficiency, and safety.
Very wonderfully put. Probably it would be interesting to do a cost-effective effectiveness
Yes.
analysis of the same, saying that the additional cost of the nerve monitoring can probably be borne by making the surgery faster and
Yes,
cutting down the
that's a
time of
great
surgery.
point. Please
Yeah.
do the study.
Yeah. I have no more questions. If anybody else wants to take some.
Yeah, we can have a few more questions or comments. I see Dr. Pooja Ramakant, IAES Secretary is there, ma'am. And Dr. Katmak has joined from Turkey.
Thank you very much. It was a fantastic meeting. Thanks a lot.
Okay,
Thank
thank
you.
you. So I think now we will proceed with the next sessions. I will request Dr. Sarah to kindly moderate the next sessions, starting with the talks.
Unmute yourself, Sarah.
Thank you so much, sir. I would request Dr. Farheen ma'am to kindly introduce the speakers for our session. And I would be taking the last session that would be implications of ATA guidelines in the Indian scenario. Dr. Farheen, over to you.
Yeah, thank you, Sarah. Am I audible? Am I audible, Sarah?
Yes, you are.
Yes, sir.
Yeah. So for the next session, I would like to invite our first speaker, Dr. Roma Pradhan, who's a consultant endocrine surgeon at Medanta Hospital, Lucknow. She will be talking about giving some insights about feasibility of active surveillance of papillary microthyroid carcinoma in the Indian scenario. Ma'am, over to you.
Yeah, thank you so much. And it was really nice hearing Professor Sosa, the recommendations and ETA. It was made so simple, and I really enjoyed listening to that. And it was just like a revision of ETA again. So what my topic is, active surveillance in India. Is it feasible or not? Let's go through the slides. So we all know about the active surveillance. This is what I have actually copied from the 2025 guidelines itself, the definition. Coming to the history of active surveillance, we all know that it was initially put up by the Japanese, where they started the clinical trial in 1993. That time we had not even were there. We were not even in the medical school at that time. So you can say it was started then. And so after they published the prospective studies, the two landmark studies, the Japanese clinical guidelines actually included approved active surveillance as a first line of treatment for patients with smaller tumors, less than 1 centimeters. So later on in 2015, we all know that even ATA endorsed active surveillance. And in 2025, of course, they have moved forward with the same thing again. So, with a lot of literature in the world here, we all know everything has been talked about which patients are ideal for active surveillance, which are not. So, this is just for everyone. Basically, older patients more than 60 years with a solitary nodule and well-defined margins, these are the ideal candidates. So in one of the papers, I found this, and this is what we are actually following about the ideal candidate, appropriate candidate, and inappropriate candidates. Uh, we can risk classify our patients so that we know which patients are ideal candidates for active surveillance and which are not. So the ground reality in India, I was working in a public sector hospital for 5 years, and these were the patients which I used to get there. So later on, I shifted to a private hospital, and of course, the kind of patients which now I treat is definitely different. So I just made a PubMed search about active surveillance in papillary thyroid cancer. So this was the thing. Total 379 results. In India, we just had 2 publications. So I'll take through the case scenarios and explain about the active surveillance, the real thing which is there, the ground reality in India. So the case one is a 30-year-old doctor. She herself is a hemato-oncologist, and she felt a nodule in her neck, a small one. She got an ultrasound done immediately. It was a 7.9 nodule there. She got an FNAC done, so that was Bethesda 5. No, what about it? She's a friend of mine. She WhatsApped me the reports to ask about it. And according to the guidelines, of course, she is one of the appropriate candidate for active surveillance. But of course, she took a decision of hemithyroidectomy with the neuromonitoring, and histopathology came out to be classic PTC and no nodal meds. She was actually sharing that she was afraid of because one of her friend also got operated for PTC and she had a node there. So she was afraid that maybe her node also will come out to be positive. But fortunately, she just had a classic PTC with no nodal meds. Coming to a second case, a 83-year-old lady from a doctor family. Her son was in army. So she got an ultrasound done, which was thyroids 4.9 centimeters. FNA was done, which was PTC again. So of course we counseled her. She was again the ideal candidate, and you can say not even appropriate because she's more than 60 years old. So an ideal candidate. Counseling was done definitely for active surveillance and surgery. But the relatives and patient, they all wanted surgery. So she underwent a hemithyroidectomy with intraoperative neuromonitoring and autofluorescence. I must mention that we do use neuromonitoring in all our cases. And the final histopathology, of course, came out to be T1A tumor, classic PTC. Now, coming to the third case. So, she was a relative of case two. She was a 44-year-old lady and she was very anxious. During the entire counseling session in the OPD, she was just crying. And that was really upsetting also. How to counsel such patients? She had a nodule of 9.7 PTC again, Bethesda. We counseled her a lot about the treatment option. You can see the ultrasound here. The only little bit frightening was the capsule here was little indentation of the capsule was there. Then of course, again, she was the appropriate candidate for active surveillance again. But, and to say that she wanted a total thyroidectomy, she preferred that, but somehow with the family and we counseled her for hemithyroidectomy. Again, it came out to be a classical PTC, PT1A. Coming to another fourth case, a 23-year-old lady who was unable to gain weight with palpitations outside report, TSH was low. She was started on pneumocazole. There was a 1 centimeter nodule on the left side. We did a thyroid scan, left AFTN. Of course, some people may object that we may not go for FNA for a AFTN, but we went ahead and it was PTC in that AFTN. So again, she was given an option. All the options were explained to her. She was also one of the appropriate candidates, you may say, because she had not too low of a TSH and she was well controlled on pneumocazole as well. But she decided to have surgery. So she underwent a robot-assisted hemithyroidectomy. And the final tumor came out to be PT1A again. Now, coming to a fifth case, which was a 35, all these cases were managed in the last 2 or 3 months. So, 35-year-old lady, FNAC, proven PTC, ultrasound, it was 1 centimeter. She had not had any baby till now. She was planning for pregnancy. So, again, we had given all her options of total hemi with active surveillance. She was also an appropriate candidate, you may say that. So she also underwent robot-assisted hemithyroidectomy with IONM, and histopathology again came out to be classic PTC. Now this is very interesting case of a 42-year-old gentleman, of course, family member of one of our colleague here in the hospital. He is in Dubai. So his ultrasound was 9.9 mm on the right side with 8.7 mm on the left side. FNAC done twice was again Bethesda 3. So we were discussing the options with him, with surgery or follow-up, and also molecular testing. So patient agreed for molecular testing, and it came out to be positive for BRAF mutations. So then it was pretty clear that we will go ahead for surgery in this case. So we planned for total thyroidectomy. We sent the frozen section of the lateral nodes, which came out to be positive on the right side. He underwent right selective neck dissection. And 1 out of 10 in central compartment and 1 out of 16 node were positive in right selective neck dissection. So this is one of the paper which is published recently from India. They had 17 patients of active surveillance and none have undergone surgery. They have a follow-up of around 7 years. But I must say that I till now have no patient under active surveillance as of now. But yes, we have definitely shifted from total to hemi as of now for the smaller tumors. So maybe somehow I thought, let's see what are the practical limitations in our country for this. The most important thing is there is need for frequent follow-up imaging under active surveillance. We all know that. And it is difficult to be met in our country as of now, especially available in big centers and big cities, not at the peripheries. And sometimes advanced imaging modalities may be required. And there's lack of dedicated thyroid ultrasonologist and patient fear of the word cancer. That is very specific. So patients actually, whenever you tell them you have cancer, nobody would like to keep it in the neck. They want it out. We all know that. And of course, second opinion. If you're going to counsel them against for active surveillance, definitely they will go for second opinion. That the doctor whom they're approaching may not be that aware of the active surveillance or maybe not be favoring active surveillance. So there's again a problem there. The most and the next, just a second. So the most important point, which I thought was also anxious doctor. Of course, giving this treatment to the patients is pretty much difficult for a doctor as well. So it's the responsibility is actually on us also. If something, then patient may blame you later on also. But of course, you have to show them the literature, whatever is available. We tell them that, yes, this is active surveillance is going on in Japan. It is a feasible thing which is there. But somehow to have proper active surveillance in our country, there are some prerequisites. First of all, we should have advanced radiology services. Then patients should be optimally counseled by providing necessary information. A lot of counseling is required for these patients. Radiologists should have adequate experience and preferably the same radiologist should be performing because they know, or the endocrine surgeon or the endocrinologist, whoever is following the patient. Then patient's commitment towards follow-up should be ensured and should be reinforced at every follow-up visit. That is important. patients should clearly communicate any possibility of future non-compliance that they may have, and any delay in the follow-up should be avoided by timely communication with the patient. So these are the prerequisites, of course, in a busy public hospital in our Indian scenario. The counseling and everything is pretty difficult because they have so many patients lined up, and we just get a few minutes with the patient. So that is one of the point. So of course, to reach active surveillance, we require endocrine surgeons, our other surgical colleagues whom the patients may seek for second opinion, our head and neck surgeons, nuclear physicians, endocrinologists, pathologists, radiologists. All need to climb together to reach to that part of active surveillance. And this is my team from Medanta. Thank you so much.
Thank you, Dr. Roma. It was a wonderful insight into the topic. And indeed, being in a corporate setup, I echo your thoughts, resonate equally with same amount of frequency. I guess I would like to have Dr. Julie give some insight into this. Would she like to comment?
Yeah, I would. It's great talk, and a lot of truth has been spoken. A couple things. One is I totally agree that I don't think active surveillance is an approach that feels right for many patients. It also doesn't feel right for many clinicians, and I will give you an example in the United States. So I work in San Francisco now, and in San Francisco, we have two sets of patients. We have patients who are very wealthy, who live in San Francisco, very privileged. Many of them like active surveillance because they live nearby, it's easy to come, they don't mind the idea of expense over time. And then we have patients who travel to San Francisco from rural California. They travel from 6 to 9 hours away, and it is superhuman to get them there once. They will never come back. And those patients are not good candidates for active surveillance. So just in my practice, I would tell you that the majority of patients are the latter, not the former. I also hear you that we at UCSF, it took us like 3 years with all the resources we have to assemble an active surveillance protocol. If you don't have a protocol that is not a Swiss cheese model where people can slip through, I think it can be a very dangerous thing. You can't do it on your own. You have to be able to do it, I think, with colleagues. So I think you spoke truth there. The one thing I would just caution about is the use of BRAF V600E. So this is a very interesting mutation, very common, right? And I think a lot of the dialogue was set several years ago when Ming Zhao published his very famous JAMA paper that showed that if you have the BRAF V600E mutation and a papillary thyroid cancer, you were more likely to succumb to your thyroid cancer. That philosophy, I think, is being debunked. And the way we've come to think about BRAF V600E in the United States is as an intermediate risk mutation. So if you have BRAF V600E and only BRAF V600E, it really, in our experience in the United States, I'm not saying my experience, is not so much that it's aggressive. However, when that early driver is paired in a mutational profile with a TERT mutation, a P53 mutation, you betcha, it becomes high risk. And so one of the reasons we did not recommend molecular testing at the time of FNA or immediately postoperatively was because we're a little concerned about how people may misinterpret BRAF V600E and potentially overtreat patients. And so we've reserved mutational testing to radioactive iodine resistant disease when you're choosing a small molecule therapy, or upfront if you're thinking about a small molecule therapy in the neoadjuvant setting. I'm interested in what your experience is in India, but that's sort of what we're coming down to is BRAF V600E by itself, intermediate risk, when paired in a genomic profile with TERT, P53, we can go through all of them. And that's in figure 8. We have a table actually in the guidelines that may be helpful as you do more molecular testing and think about risk stratification. Thank you for your comments. I actually really love them and I learned a lot. So thank you.
Thank you, ma'am. Is there anyone else who would like to make a comment or ask a question? Okay, if not, we'll move on to our next speaker. Unfortunately, Dr. Ramya, who was scheduled for the next talk, is not available, has gone in for an emergency. So I would like to invite Dr. Smita Rao, who is an assistant professor at Breast and Endocrine Surgery Unit in charge at K.S. Hegde Medical College, Mangalore. Ma'am, I invite you for your talk on prophylactic central compartment lymph node dissection in high-risk cases.
Hi, just give me a moment to share the screen. Is it visible?
Yes, it's there.
And it's full screen as well?
No, it's not full screen. Yeah, now it is.
All right. So Ramya had to do hemithyroidectomy versus total thyroidectomy for PTCs. And my topic was prophylactic central compartment neck dissection for high-risk PTCs. So to begin with, to define the central compartment, as we all know, it's level 6 and 7, between the carotids extending from hyoid to innominate inferiorly. Why is the controversy about prophylactic central compartment in the first place? It's a difficult procedure wrought with a lot of complications. It has higher complication rates. Risk versus benefit is almost leaning towards risk more than benefit, and insensitive preoperative imaging for this particular compartment. So does it really reduce recurrence rates? We don't have, we probably have enough data to support reduced recurrence, but not enough data on survival or recurrence-free survivals. And the consensus is mixed on the opinion of whether it needs to be followed universally or not. So this is a study from China which compared prophylactic ipsilateral versus this thing. It was a meta-analysis. It had no RCTs, and most of our meta-analysis do not have RCTs in this particular section. So it had 6 studies with about 1,500 and more patients. The surgeon's preference bias was for central compartment neck dissection in this particular analysis, with a lot of studies in the meta-analysis had the surgeon's bias. The follow-up of the studies were quite short to conclude something that could be superior as compared to another procedure. So this was another meta-analysis which was published recently by a group in China. What is interesting to note here is it compared total thyroidectomy alone with total thyroidectomy with prophylactic central compartment neck dissection. And it said that it did not increase complications. It did not comment about survival rates at all. The idea about not doing or doing prophylactic central compartment neck dissection is purely because, as a surgeon, it is difficult to go back to that compartment for a reoperative surgery, and you're worried about recurrences in that compartment. I would also like to discuss 3 scenarios. These are not real patients, these are scenarios. So patient 1, a 40-year-old lady, 1.5 centimeter tumor. enlarged ipsilateral central compartments on ultrasound, and FNA was Bethesda 4. And patient 2 was a 52-year-old lady with a 3 centimeter tumor, right lateral neck nodes on ultrasound, and FNA Bethesda 6. So your patient 2 here is a high-risk PTC according to the guidelines, the recent guidelines that were out. So, and the patient 1 falls under low-risk PTC. Um, uh, Particularly because of the size of the tumor and not because of the status of the central compartment lymph nodes. And the patient 3 is a 48-year-old lady who's benign on FNAC and ultrasound. It was thyroid 3 nodule. She underwent a right hemithyrectomy, which turned out to be a papillary microcarcinoma. Again, comes under the low risk PTC. So the oncological rationale behind doing prophylactic procedures in papillary thyroid carcinomas is possible removal of the source of recurrence, decreased morbidity due to revision surgeries, which we may have to do in case of recurrences, precise staging for the use of radioactive iodine, which is probably not existent today because we do skip radioactive iodine for a lot of patients. Increasing thyroglobulin accuracy as a predictive factor, again, not done because we are also going into active surveillance as an active mode of surveillance for papillary thyroid carcinomas. But since we are sticking to high-risk papillary thyroid carcinomas, yes, increasing thyroglobulin accuracy is a concern. Assumption of OS benefit from most of these studies, whereas overall survival has not been studied in majority of the studies that have been quoted. Positive sentinel lymph node amounted to 2% median rate of recurrence, but we do not know if it was a sentinel node that was excised. We have no particular way to know. This is another study published by an Italian group, which very clearly listed and which was later adopted in the ETA guidelines as well. It consisted of T3 tumors, which is the high-risk PTC group. And the impact on survival in this high-risk group was significant. And the recurrence in low-risk cases were not commented on. So central compartment and central compartment lymph node dissections are different, is what they mentioned here. So central compartment per se, they also gave a very nice classification where they classified this area into area A, area B, D, and C. So as you can see, the entire area that they have quoted here is under level 6 and level 7. But the approach to this area is slightly difficult. And what is more challenging is that we don't have particular imaging which can give us a clear picture of this entire compartment. And that is exactly why the controversy exists in this area. Another study from the Korean group, again consistent of majorly retrospective studies, all of them non-randomized. And there was a significant selection bias as well in pertaining to the size of the tumor. This is another group from Egypt, which also studied, which compared total thyroidectomy with and without prophylactic central compartment neck dissection and said that there was no difference in complications or recurrence rates. Another study which spoke about low-risk thyroid cancers, very large number of patients, but they did say that omission of prophylactic central compartment neck dissection was an independent risk factor for low-risk PTCs, but a relatively older study may not hold good today. Lastly, another case which commented about T1, T2 tumors, but positive central compartment nodes with an average size. What is interesting to note here is the average size. So the average size that we come across in our population is probably ranging between 2 to 2.5 centimeters, whereas most of these studies have an average size of 1.1 to 1.5, and the meta-analysis quoted here with an average size of 1.6 centimeters. Again, a follow-up data of 10 years was accounted for, and they did not find any difference in the recurrences rates as well as complication rates. This is another Chinese group which published a meta-analysis very recently. What is interesting to note again here is that it did not demonstrate significant efficacy in improvement of oncological outcomes in low-risk patients. They also motivated the surgeons to make individualized decisions about what they need to prefer in that particular patient. What they noted were these high-risk factors: younger age group, presence of extrathyroidal extension, higher TG, larger T size, which is T3 and T4, male population, lateral compartment positivity to begin with, and BRAF positivity. Some of these are included in ATA 2025 as well. And one of the protective factors that they mentioned is the presence of thyroiditis, which is very common in our population. So this is the summary of the guidelines that were proposed. We have ATA 2025, which I will discuss in the next slide. This is the earlier guidelines. What is important to note here is T3, T4, they always say prophylactic central compartment dissection may improve regional control. They're very clear about the high risk group here, both the British Thyroid Association, European Thyroid Association, and NCCN. And in the ATA 2025, again, it's a conditional recommendation based on the risk versus benefits as to reduce the complication rates. So they very particularly mention that T3, T4 tumors, it may be considered. Prophylactic central compartment neck dissection may be considered. Whereas for a low risk, it is very clear and it's a strong recommendation. It should not be considered at all. And in a lateral compartment positive patient, you definitely have to go ahead and clear the central compartment as well. So the complexities in this particular section of the guidelines is that the few studies that were quoted under the recommendation, one of them suggested that the lymph node ratio more than 0.26 was an independent predictor of regional lymph node recurrence. Whereas an average recurrence rate was pointed out as 3.8% in one paper, and the more recent paper by Choi et al. Had 21.2% recurrence in the central compartment. So what was an interesting thing to note with another study was that they mentioned that they required to treat 31 patients to prevent one single recurrence. So in the chase of reducing recurrence, are we really offering survival benefit to any of these patients? Probably not. And that is why we have moved towards not doing routine central compartment neck dissections in low risk and considering it only in high risk patients. So the challenges are that the feasibility calculation for these patients needs to have a very high population. We need to have at least 5 RCTs with a larger follow-up, which is practically not possible. The number needed to treat per recurrence would be very high. No difference in structural or biochemical recurrences in most of these studies, so it is difficult to incorporate these into the guidelines with the present data available. So change may not, I am a strong proponent of change, but change may not always be required. This is a paper by Professor Kwan Yang Du in 2010. So at that time, he said reoperative central compartment neck dissections for papillary thyroid cancers has lower rate of temporary hypocalcemia, same rate of other complications, and same rate of recurrence. And we probably stand with this line even today. And that is why change may not be pertinent in this particular scenario. So with the patients that I discussed earlier, patient 1, plan was total thyroidectomy of a bilateral central compartment neck dissection. If willing for a second surgery of a hemithyroidectomy with unilateral central compartment neck dissection. Patient 2 was a clear-cut high-risk case, so a total thyroidectomy with bilateral central compartment neck dissection. Patient 3 was a microcarcinoma, clearly low risk. Compliance probably is not a problem anymore in a low resource constraint setting country like India as well. So I would definitely follow up that patient with no further intervention and no afterthought at all. So to conclude, T3, T4, high-risk tumors, positive lateral compartment disease, positive central compartment, prophylactic central compartment lymph node dissection probably is the way forward. It is the era of personalized medicine, as Professor Souza mentioned. So it needs to be individualized to that particular patient and not one size fits all. Selected patients with bilateral central compartment neck dissection, and if you are addressing only one side and doing a hemithyroidectomy, I would not venture into the contralateral side unless really necessary, because the whole point of a reoperative surgery or avoiding complications is defeated. One should always audit the complications when we are routinely doing central compartment neck dissection so that we remain very low in our complication rates. And we do need more studies with high quality RCTs in this area to probably conclusively say that it's a strong recommendation in this category. Thank you.
Thank you, Dr. Smita. Very well put. So I understand that you do not propagate prophylactic CCL-ND in your cases, and the points are quite practical for your setup. Dr. Roma, what are your views on being in a corporate setup?
Yeah, so basically
What
for
do you
me,
practice in
yeah,
general?
what I practice is if I'm doing a hemithyroidectomy for a patient, so I will not go for CCLND as of now. And but now I'm like shifting from total. Initially, I used to do total for all PTC cases, but since like a year or two, I've switched over to the low risk cases. We have started doing hemithyroidectomies and not doing prophylactic for low risk and small tumors.
All right. I had a bit of
Because
doubt
I
regarding
think
scenario one.
we do see the central compartment, and if nodes are seen, we of course we can assess intraoperatively. We all do that because we all
Absolutely.
know that ultrasound is not a good modality for central
Mhm.
compartment nodes,
Mhm.
since we will not be able to visualize those nodes. So
Okay. Anybody else would like to comment? Dr. Pooja, anybody from uh, a bigger academy, a bigger setup practicing?
I have a question.
Yes, Dr. Shashi.
Yeah, this is for Professor Julu. So, I have been going through that this ATA 2025. This ATA has divided into low risk, low intermediate, and intermediate height, then height. So, in low and low to intermediate, it's written PT1, T2, and any lymph nodes in low risk less than 5 lymph nodes, or low to intermediate more than 5 lymph nodes. So, when we do not do a prophylactic lymph node dissection, why did this come into the picture?
This is for Professor Souza, I suppose, right?
Dr.
Yes,
Julie?
yes.
Is she with us? Professor Souza?
Hmm.
She is connected though.
Yeah, she is connected.
Hi guys, did you just ask me a question? Because because we've gone over time, I'm actually having to answer faculty members who are asking me questions. Sorry.
So there was
Um,
a question from one of our friends here about
Yes.
offering prophylactics. Why are we not offering prophylactic central compartment neck dissections in low risk PTCs, which is T1 and T2? Am I
Yeah,
correct?
the reason is
No,
because rarely do you see in those patients macrometastatic clinically significant disease. And the eradication of micrometastatic disease, I think we're changing how we think about micrometastatic disease as opposed to macrometastatic disease. If you want me to look in my crystal ball and tell you where I think prophylactic central lymph node dissection is going, I think as we learn more about the molecular underpinnings of tumors, okay, meaning if we eventually come to the point where the cost of molecular testing is reduced and we are able to do more of it for more patients, we can better personalize whether to do central lymph node dissection, meaning there will be some patients with T1, T2 tumors who may have a BRAF TERT mutation where you absolutely probably should do a prophylactic central lymph node dissection. But the overwhelming majority of these small tumors will not be that, right? They will rather be low risk tumors. And I think prophylactic central lymph node dissection in the United States would not generally be done by high volume surgeons. The average surgeon, sadly, in the United States who does thyroid surgery does one a year. And so when they do that one, it will come with a greater risk of hypocalcemia and nerve injury. So It's kind of too blunt a sword. I appreciate that point, and I think I would like to see in 5 to 10 years the cost of molecular testing come down, and we use molecular testing to answer this question. Thanks.
I think he also mentioned something about the number of lymph nodes, correct? Dr. Shashi, can you ask the question again?
Yeah. So the thing is, when we say that in ATA low risk and low to intermediate, it's PT1 and T2, but still there are lymph nodes being considered. So what was the basis on which it was considered the lymph nodes? Because we usually do not
Yeah.
prefer to do routine prophylactic central compartment dissection in these.
Yeah, with regard to number of lymph nodes, so I do not think routine prophylactic central lymph node dissection should be done for small tumors. I take a metered approach in larger tumors. Like if I have an encapsulated 4 centimeter tumor, I have a follicular thyroid cancer that I think I'm dealing with, I wouldn't do it. In terms of lymph node yield, lymph node harvest, there's an extensive discussion in the guidelines around how many nodes constitutes adequacy of lymph node dissection. I think in the end, though, we couldn't arrive at a final number or conclusion, hence it's not included in any of the recommendations, only in the discussion.
Thank you.
Uh, uh, Thank you, Professor Sosa. I know that it is Monday morning, and I have texted you also that you may leave the meeting because it will go on for some time, I think, because it is very interesting for us. So you may leave if you have any other commitment. Thank you so much for
Thank you
joining.
so much. I appreciate everyone, and I hope to see you at an international meeting soon. You all are welcome to come and visit us in San Francisco.
Yes, sure. And I will also I will get back to you regarding IAES conference next year. So
Okay,
I will get back to you soon. Thank you so
sounds
much.
good. Have a
Yeah.
great evening in India. Bye.
Bye. Thank you. Thank you so much.
Thank you, the previous speakers. Now I'd like to invite Dr. Sarah to take over the next session. Dr.
Thank you,
Sarah?
ma'am. A very good evening to everybody. I am Dr. Sara, Assistant Professor at the Department of Endocrine Surgery at Dr. Ram Manohar Lohia Institute of Medical Sciences. And I would first like to thank the ever enterprising Sanjay Yadav sir for giving me the opportunity to moderate this session, which is quite an interesting session where we'll be discussing regarding the ATA 2025 guidelines in the Indian scenario and what challenges we face and what we can do to overcome them. So with me, I have a great set of panelists, Dr. Sasi Molly, Dr. Ramya, probably she's not able to join us yet, Dr. Farheen, Dr. Spandana, and also Dr. Smita. I'm really happy to have you all on board. And without further ado, I think let's begin. So, is my screen visible?
Yes, it is.
Okay. Do we have Dr. Sudhi ma'am and Dr. Spandana as well?
Yeah, I'm here. Good evening, all.
Okay. Okay. So, I've divided our discussion into 3 parts, and the first part will be on the challenges that we face in diagnosis and surgery. So I think I'll ask a question or two to each of the panelists. All of you can have your audios open and your mics as well. And to whoever I ask the question, please try to give a clear, crisp answer. The others can weigh in after the particular panelist has answered. So the first question is, the ATA guidelines have now incorporated active surveillance and ablation as appropriate treatment options for micro PTC. Considering the psychological impact of cancer diagnosis in our patients and the medical legal temper in India, how do you suggest we motivate our patients to opt for these newer modalities and gain their trust? So I would ask Dr. Sasi Molly to please take this particular question.
A very tough question. In fact, what ma'am has already answered, Roma ma'am. And I did also have a couple of patients which had similar scenarios which ma'am had explained. Papillary microcarcinoma never wanted to go for active surveillance. Honestly, I have only one patient who is still on active surveillance for the past 6 months. And so, as you rightly, ma'am was telling, the psychological impact, first of all, the word cancer. Secondly, uh, as ma'am was telling regarding the patient's education status, as well as the second opinion, third opinion things, give a lot of insights to the patients as in to go ahead with surgery rather than doing active surveillance. That is first thing. Second thing, yes, regarding the ablative techniques, yes, some patients do ask for that, but as of now, only the Korean guidelines have some ablative techniques incorporated into microcarcinomas or less than 1 centimeter. At least I don't think in India any of the surgeons are practicing. Maybe some intervention radiologists would prefer, not my intervention radiologists. They don't prefer.
I think if we are to ablate thyroid nodules, whether they are benign or malignant, it's the endocrine surgeons who should do it. And there are a few of our seniors who have started doing it.
Yeah,
Although, yes, of course, considering papillary microcarcinoma undergoing ablative procedure, that is something which needs to be further researched in India, I feel. I think the word cancer itself is very psychologically damaging to our patients, and most of them don't want to because, as Roma ma'am actually showed her entire series, none of her patients want to continue with the active surveillance.
If I
in
Anybody?
fact,
can
last
pitch
week
in,
I had another
Yes, yes,
patient
yes, please, Dr. Smita,
who
yes,
was
please go
having
ahead.
6 millimeter
let him
nodule,
pitch.
and I have given the option of active surveillance. She said no, and she wanted a surgery.
Right.
So if I can pitch in, I think again cost effectiveness matters here. See, calling the patient to your clinic every 3 months is probably more difficult for the patient rather than doing at least a hemithyroidectomy. So I'm not still convinced that in our scenario, active surveillance can be extensively practiced yet.
True.
Yeah, so if I want to add, we should first have a proper guidelines or the protocol that we need to follow for active surveillance, 3 months, 6 months, or yearly, what we need to follow. So that is very important. At least the guidelines, your local guidelines can be done. So at least if we start and we echo the same things, because I'm sure in Lucknow we may opt for that because we have 4 or 5 institutes that are managing that. And if we all echo the same things, then maybe the patient does get convinced and we may start with that. So
I
I'm not sure if anybody of you are having any patient under active surveillance at present.
So I had one
Wow.
patient who had a 5 millimeter nodule to begin with, and we asked her to remain under active surveillance, and she initially agreed. But after 6 months, her nodule was 9 mm in size, and the thyroids had become from 4 to 5. And that is when she panicked and she said, "I don't want to, continue with active surveillance." And we have operated on her. We have done a hemithyrectomy. The pathologist now says that it could be an FVPTC and not a classical PTC. I think
think
you're right, ma'am. We need standardized protocol for
Surveillance.
practicing active surveillance. Spandana, you wanted to say
yeah,
something.
I agree with Dr. Roma. To have a highly motivated patient, I think we need to have first highly motivated surgeons because that would translate to good counseling. Also, as ma'am said, having a written SOP for follow-up would actually make the patient more confident that there is an actual solid plan of action in place. So that lowers the anxiety of the patient, and it also helps us in medical legal defensibility if we have a written follow-up protocol.
True. I agree. Okay, so moving on to our next question. The surgical extent of thyroid carcinoma is based on the size as per ATA is for a 2 to 4 centimeter tumor is either lobectomy or a total thyroidectomy. Now, Dr. Smita, I want you to take this up. In the Indian setup, what are some pressing non-medical factors that you would consider when deciding the extent of surgery in such cases? Are there any at all? Or what is your practice
Um,
in general?
Not really. Probably in the earlier scenario, I would say there was a difference between hemithyroidectomy and thyroidectomy. the cost wise for the patient, but not anymore. It's almost the same even robotically. So the surgical time is what comes into consideration. So if I am planning lobectomy, then I don't think there would be any other factor that would stop me from doing it, unless there is a risk factor that uh, tells me not to do a hemithyroidectomy in that particular patient. Um, because most of the high risk conditions in a patient which can make surgery difficult can be managed in a good setup now. We have a multidisciplinary team in most places that we, at least most of us are operating. So I think managing a patient for a hemithyroidectomy or a total thyroidectomy need not be decided based on the other factors.
Right. Anybody else who would like to weigh in here?
Yeah, so for the non-medical factor, I must say the place from where the patient is coming. If he or
Right.
she is a rural patient,
Yes.
definitely that will matter to me, whether I'm doing a hemithyroidectomy or total thyroidectomy for a patient. So that is one of the non-medical factor that you may consider.
And also the distance that the patient travels to us. The patient may or may not be, from a rural background, but a lot of times we have patients coming from Nepal and they don't want to come back to us. I think the distance and the education level of the patients do matter.
But again,
True,
then
but a lot of my patients do a video consult at least, and they share all the reports. So I think COVID has changed this bit of the difficulty. I would still feel, unless it's an international patient, like Madam said, rural patient is still not a problem. Most of them are compliant now. They come back in 6 months if you call them, at least once a year, if not 6 months. So that is not a deterrent for me, I would say.
yeah, I was saying if distances are a matter, then it's also about the rural population not compliant to, maybe, may not be compliant to thyroxine supplementation altogether after a total thyroidectomy. I guess that's also what favors a lobectomy if just education background is the a problem.
Yes. Okay. So moving on to our next question. How can a surgeon, such as yourself, Dr. Spandana, practically implement the diagnosis, assessment, treatment, assessment, that is the data framework, considering that pathology and molecular tests are not routinely available for our patients or they're quite expensive for all our patients?
For the data framework, again, we do have a lot of cost-effective uh, uh, protocols that we use in our setup, such as for the diagnosis and assessment itself, just a good quality ultrasound and a cytology reporting with a good assessment of the clinical features and the ultrasound features are sufficient. Not all require molecular testing, and that is not also something that's readily available in all areas. Also, treatment, as has already been discussed, appropriate treatment according to the patient and their having realistic expectations, keeping that in mind, and also based for the assessment after surgery for the risk stratification, it is based on affordable tests in our settings, such as just a good clinical examination, ultrasound, high resolution, good ultrasound, with or without testing of the TG. Again, molecular testing is not mandatory, and as has been told in the current ATA guidelines.
Right. Dr. Ruma, I would like to ask you, are you doing molecular testing for all your patients in your setup?
No, no, not all patients. We give them an option, of course, for molecular testing. See, patients are well read. They read on the internet, they know what to ask. So if you're not giving them that answer, they will definitely move on to the other doctor. I must tell you, this is what happens. So you have to give all the options to the patients available in present right now. You cannot say that patient cannot afford. You cannot decide on their behalf what they can afford and what cannot. So at least mention that this is available. It may not be possible for you, but it's okay. We have other options how to manage those patients. So this patient which I mentioned of molecular testing, he absolutely agreed for molecular testing immediately, and definitely that did help us to take a decision on surgery or not. So of course not for all patients at present, but we are giving them an option when there is Bethesda 3 category, definitely.
Also, I have one question. This may not be for the preoperative, particularly for the preoperative setup, but post-operatively also, if we are getting molecular testing done on the specimens, and if we do find BRAF mutations or TOT or P53 mutations, does it really have a significance, therapeutic significance in our scenario? Because we do not have those targeted drugs available with us right now.
Yes, not therapeutic, but definitely you know what you are dealing with. Suppose you
Exactly.
have left some part, because once you know that patient is BRAF, you can tell them that this is little bit high risk, you have to be under follow-up. So even they know it. And the most important thing is RAI sensitivity, because you know if it is BRAF positive, so these tumors may be not that sensitive to radioactive iodine. You may get them later on, you may have rising TG, and then these problems may crop up. So if you have you already informed your patient beforehand, they are also ready for it. They understand your problems.
It basically makes the patient and the physician alert
Definitely.
about
It's
the
very
further.
important for us to become very confident of what we are dealing with.
I agree with you completely. Dr. Smita, your input on this, please.
It has been discussed by everybody, I don't think it's an issue in diagnosis. So we have a good quality ultrasound and a reliable radiologist and an FNA. That should be good enough. And treatment, again, most of us, um, you don't necessarily need nerve monitoring in every patient that you do. So you can still manage it with a good surgeon. And post-operative thyroglobulin levels is that if that is your concern, then there are a lot of places where the specimen is outsourced now. A lot of places which do not have in-house thyroglobulins can be outsourced, and the reports can be given. So and most of these patients are willing to do that as well. So I think managing the data framework is not difficult. We have our own resource constraint methods that we follow, and I think they are good enough, almost reaching the standard of care.
Yes, they're quite put in place.
Yeah.
Okay. Dr. Fareen, the next question is for you. A notable
Just
shift away from the prophylactic
if I'm not
central
teaching.
compartment lymph node dissection has been seen in the current ATA guidelines. And do you think we can apply the same set of principles for our patients? If so, why or why not? I think we've discussed this question, but I think a quick recap can help for others who have probably joined late.
Yeah, I guess the answer would be yes to it. Yes, it could be followed. Because most of the biology of PTC that we see in Indian scenario is just like what we see worldwide, except that our patients may present little later because we usually don't have screening programs and things like that. Other thing is our burden of Hashimoto's thyroiditis, which may complicate the situation for us. So, if patient has a high risk disease and there are lymph nodes, you could probably use facilities like a frozen section intraoperatively, or just do a hemi CCLND if a nerve is at risk. Otherwise, just based on low risk features, just leave the CCLND and go ahead with just a lobectomy or a total thyroidectomy alone.
Right. Okay, Dr. Sasi, the ATA has finally given a recommendation that it's not good to, there's no real need to drain the thyroid bed, but our habits die hard. So, what steps can you advise young surgeons to motivate them to start abandoning drains where they are not required?
Uh, so basically, the thing is, I mean, what I follow at least, standard hemithyrectomy, I don't put a drain.
Right.
Total thyroidectomy depends on the size of the nodule and if at all single compartment neck dissection is done
Yes.
or little bit of retrosternal extension is there, then probably I'll think of drain. But yeah, if it is again a standard total thyroidectomy, I have not all, but a few couple of patients I have not put drain. They did well except for a little bit of swelling, which I have to just educate them. So thing is, you have to choose the patient first, educate the patient. Whatever the amount of swelling or the seroma formation can be there, that has to be managed, with a little bit of counseling. That's it. Until unless it causes a lot of pain, you don't have to even put in a needle and aspirate. So this is the thing which we have to do. Sarah, just one thing I wanted to the previous two questions before this regarding the data. Okay. So I just want to clarify one thing that data is a framework that is to help both clinician and the patient to take via the clinical course right from beginning of the diagnosis till the follow-up. So it may or may not include the molecular test necessarily. So it's not mandatory that it has to be there. As Pandana said, Smita said, everyone told that. So it's not at all mandatory that there has to be a molecular testing. So it's only the clinical course, and with a good imaging and FNAC, you can manage these patients. Second thing is that in that when do you get a molecular testing? Yes, mostly in the recurrence scenario we do get it. Otherwise, you don't have to think about it. Only thing I wanted to ask Roma ma'am one thing, that when she did the molecular testing for this AUS, which molecular testing was used in Indian scenario? Because we usually don't get a Thyrosic version 2 or 3.
So
So I
MedGenome
just
has
wanted
come
to
out.
ask
Yeah, so MedGenome has come
thyroid
out with
track.
this thyroid track. So they do it on the FNA sample. Usually, sometimes they are inadequate. They have to repeat the aspirate. But in our patient, it was done at one go. But this one of my friends who had PTC, so she even I advised the thyroid track for her. She got her samples done twice. I think they were not able to recover that. So she could undergo molecular testing. So now, post-operatively, she has already sent her sample. Because she's read a
Okay.
lot. She's a hemato-oncologist. So she has read so much that she is just asking me just to validate her things. So basically, people who are well read, you will get those patients and they will ask for it. It's all demand and supply. You have to.
I did have two
Definitely,
patients who asked for that. So we also got thyroid track.
Yeah.
And
Yeah. No, Dr. Sasi, go ahead, please.
yeah, the third thing regarding the mutations. So the mutations done on the thyroid nodule, they are basically divided into three categories, that is low, intermediate, and high. So in low risk, RAS is included in the low risk, BRAF is included in the intermediate, TERT and P53 are included in the high risk. So when the question was asked regarding the management, only if you have done hemithyroidectomy and these patients are subject to the molecular testing, and then if RAS comes, you can probably wait. BRAF comes depending on the patient, and if TERT or P53 is there, definitely go ahead with completion. Also, as ma'am said, depending on these mutations, there may be radioiodine, refractoriness or ability and stuff.
Right. Your point is very well taken, Dr. Sasi. Thank you so much
If
for
I may, Dr. Sara, if I may opine on this current question on drains.
yes.
In my opinion, younger surgeons are more flexible in adapting new and evidence-based practices, and it's more about rethinking about long-held perspectives. So, if experienced surgeons begin demonstrating that thyroid surgery can be safely done without placing in drains, the younger generation will automatically be led by example.
I think the reason why they cannot do it more frequently is because they have seen, huge sizes of goiters, which we are
So maybe
probably.
we could start small, maybe not placing drains in benign cases, and then not placing drains in patients who have undergone CCNE, then transitioning towards those who have undergone lymph node dissections.
If
Correct.
I can add, so when I went for the robotic training in Korea, so they actually mentioned that they put a drain even in a hemithyroidectomy because they have had a death due to not putting a drain in a hemithyroidectomy. So I wouldn't mind putting a drain for a day in a total thyroidectomy. Hemithyroidectomy, I routinely do not put drains. But drain versus no drain is a personal surgeon's choice, I suppose,
So I
because
must
it does not
confess,
make the.
I put drain in all my patients. I must
Yeah,
confess,
so the patient
many
goes
or
home
whatever.
without
It's
a
my
drain.
personal
So I
choice,
think
and I
it's,
do it. Yes,
yeah, it makes the surgeon sleep well. That's all I
yes,
think.
Dr.
that's
Yeah.
Smita, I'll
That's
just
the favorite
add
statement
one
of all
thing.
our senior surgeons
Robotic,
to say that.
see, robotic
They
is
want
a
to sleep
little
well.
different ball game because the area of point of entry is different and the amount of dissection is more. Okay. So you raise the flaps and keep doing it. I think Nawal Bansal sir has a case where he has done a robotic parathyroidectomy and still he keeps on aspirating 600 ml, 500 ml. Okay. So robotic thyroidectomy is a different ballgame. I think we are talking about the conventional one.
Yeah, we're talking about conventional, basically. Robotic,
Yeah.
there is no doubt that we would obviously drain because the point of entry itself is completely different. And in fact, that's basically remote access rather than minimal access, to be honest. So there's no
Others,
doubt about that.
may I add something?
Please go ahead, sir.
Yeah. So actually, I do not use drain routinely in hemi or total thyroidectomy. So I hardly use it in 10% of my patients after hemi or total thyroidectomy. And I have never faced any issue. Only thing is that few patients may require seroma aspiration,
Mhm.
that is there, but patients are very happy. Those patients have good like quality on next post-operative day
But
where I
like Dr. Sanjay, you said the other day that the reviewer had mentioned that the surgeon needs to be this
yes,
particular
yes.
surgeon if you're not putting the drain.
Yes, yes, that is
Yeah.
absolutely true.
Yeah.
That is why I'm saying ki we are all endocrine surgeons. So I think we all have same kind of technique, same kind of meticulous dissection. So I think most of us should be confident in not putting drain. And as someone suggested that yes, we may start from smaller nodules, which I did actually. Then now I am confident and I don't push drain for even big nodules. So
Dr.
Right.
Sanjay,
that is
can I
my
ask,
policy. Basically. Yeah.
do you put compression dressings or it's the routine, just the normal dressing?
No, no, routine dressing.
So basically, I don't like that seroma the next day and the patient is like complaining. So it becomes very cumbersome. So put a drain for one a day. I am happy. That is the most important thing. Baki rest, everyone is choice. I agree ki people do not put drain now. That's okay, fine. I think we should accept
I
that.
think to each his own, everybody should be
Yes.
comfortable.
Yes.
Yes, yes, right.
Okay. Um, Dr. Smita, this question is for you. A standardized histopathological reporting for thyroid cancer in India can be challenging due to various factors. So, how can you, as a surgeon, overcome this challenge so that your life and your patient's life becomes easier? Because I've seen pathologists and surgeons fighting a lot over certain reports.
It's a work in progress. So first of all, you need to probably prime your when you're in an Apex Institute, you have a standardized report. But when you go out and practice, is when you find out the difficulties in reading the report. So you probably need to prime your pathologist as to what you need in the report and follow a standard protocol. And eventually, they get online with it, and you do get everything that is necessary in a report. So probably try and talk to one particular pathologist, send all your specimens to them, call them up after every patient, ask them the details if they are not mentioned, and ask them to mention it so that they're adept with it in the next report. This is what I have tried to overcome. I mean, you used to overcome the challenges that I had to face earlier. But I'm sure every person who goes initially to probably a rural place may be a bigger challenge. But in Tier 1, 2, 3 cities, it's not a problem to manage a good histopathology report after a while. It may not be immediately, but after a while, you can definitely work with your pathologist to get to something, get everything that's required for you in a report.
I agree with you. I think there is a saying that goes that what the mind doesn't know, the eyes don't see. So I think we as surgeons need to talk to our pathologists beforehand, show them the clinical profile of the patient, and explain it to them that we are looking for such and such a thing, and kindly look into the histopathology for these particular factors, and please report them. I think that would be a much easier way forward for all of us, especially when we move out of our institutes and go into private practice. I think all of you would agree with that.
Yes, definitely.
Right. So moving on to our next set of questions, which is based on follow-up and survivorship outcomes. So recombinant TSH has now become the preferred method for preparation of RAI therapy post-surgery in thyroid cancer patients as of ATA 2025 guidelines. So how feasible do you think this is in our resource constraint setting, considering our patients don't come from a very financially stable background? Dr. Fareen, you may take this up, please.
Yeah. So when this resource constraint setting comes in my mind, there are two things. One is the financial conditions of the patient. Second is our own resources, the availability of iodine in our country and in the limited institutes all over our nation. So there are two things to it. So while the patient waits for availability of iodine, leave alone the corporate settings, the major tier 1 cities, I think rest of the nation actually has scarcity of iodine availability for the patients in time. So most of the patient ideally have to wait for 1 or 2 months to get some iodine. So I think recombinant TSH in our setting would be an ideal in a setting where patient has TPA, patient has the finances are good, and iodine is available readily. Otherwise, the preparation of the conventional preparation, 1 month waiting, and this goes along the way. So I don't. In our country, it's a mixed thing. Both the resources availability and the finances both are precarious.
Agreed. Because a lot of beneficiary schemes don't have thyrogen in their so-called codes, and patients do find it very difficult. So I think for us, sticking to the basics is what is more important.
I remember as an MCH resident, our patients had to wait a minimum of 3 months to get iodine. While
Okay.
practice
So with that thought, the next question I would ask Dr. Roma ma'am and Fareen ma'am, both of you. You consider a patient with a poor financial support who has developed very early recurrence after an extensive surgery for an aggressive type of PTC. The surgery that was done for her was R2 resection. And while she was on withdrawal therapy from LT4, she developed this recurrence. So now, what would be your next plan of action in managing this patient? I want you to remember that she belongs to a poor, to a low socioeconomic status. There is no way that we can help her with thyrogen. So what comes to your mind that we can do for her?
if it's
Because
operate the recurrence, I mean, it has to be a really aggressive and probably a not a well done R2, as you said, resection. If it's operable, you need to operate. Otherwise,
true, true. We need to operate, but also when we operate on this patient, we need to keep in mind that as soon as we operate her, she should be ready for radioactive iodine ablation in the immediate post-op period. Wouldn't you agree with that?
if
So
it
while
is the disease status, then it would definitely be already metastatic or something like that.
So it,
So
it
I
is a
think
localized, it is localized to the neck. It's not, there's no distant metastasis per se.
So
But
why don't you give radioactive iodine first? Wait for the time and give her this, at least see what is the result and then go for further action.
so she has developed a huge lymph
Nodal
node,
mets. Nodal mets.
nodal
while
mets.
for
So
the
this usually happens in,
While
yes.
waiting for the
Yes.
therapy. So now that her TSH is around 12, 13 or 14, it's not touched 30, it's around 12, 13, 14, and we want to operate on this patient. Before we operate on her, we are actually giving her thyroxine suppression therapy for the thyroid profile to come back to normal, and then we'll take her up for surgery. Soon after surgery, we need to give her radioactive iodine therapy. So in the interim, what can we do? Do we have any other options? Would you consider this may be far-fetched, but would you consider external beam radiotherapy in this patient? Or would you
Not
consider
for lymph nodal mets, not for lymph nodal mets, not.
right, exactly.
No,
Or would you consider tyrosine kinase inhibitor?
that
again,
would
poor financial status. So maybe
Yeah.
do the
Not
surgery,
ideal.
meet again
No,
for
but if it's
the
accessible, why not surgery? If it's lymph nodal mets and accessible,
surgery and then,
yeah,
yeah, yeah.
surgery, because the conventional teaching is that you don't do radioactive iodine after radiation. You always do it before that. um, there is some amount of reduced uptake is what is told. So radioactive iodine, you need to put the patient up on the list if the patient is waiting. Particularly, I think we have only two options: withdrawal or thyrogen. And like everybody has discussed, we don't have patients who take thyrogen voluntarily. So there are, I have single digit patients who have taken thyrogen. So majority of them go with thyroid hormone withdrawal only.
While you're keeping the patient on thyroxine withdrawal, would you like to use LT3 in any way?
That is an affordable option. The endocrinologists
Mhm.
do prefer using LT3 these days.
Right. Because
Yeah.
the duration that is required
Yes. Yes.
is less
Yes.
the TSH.
You don't need to, yes, correct. So you can withdraw and then immediately subject the patient to something. So that is an advantage, yes, with the
Yeah.
levothyroxine.
But then again, if it's a surgery that needs to be done, you really need not worry about the TSH because it's the anesthesia part which patient will really wake up. I've seen patient getting operated at a TSH of 40 because the surgery was required. It doesn't matter.
You're talking from real world corporate experience.
Yeah, ovary cannot wait.
But there they won't operate at 40 TH.
Corporate experience is very specific. In the rest of the world, the anesthetists do not agree at TSH of 40.
Exactly my
Nobody will.
point. Okay, so moving on to our next question. What are the long-term survivorship issues faced by our patients that are different from those in the West? Dr. Sasi, you could take this up, please.
So long-term survivorship again it's based on both factors, the tumor factor and the patient factor. Of course, how well the surgical clearance has been done. So everything, if it is a low risk and the clearance has been done properly, I don't think it's any different from the West. And any aggressive tumor, even that I don't think it should be different from the West because it will come back. So I don't think there is any big difference, at least as of now, according to my experience. Probably Roma ma'am or someone else could add.
Do you have any issues in their follow-up or
At least
in
as
how
of
they
now, I
respond to
don't have.
suppressive therapy, thyroxine suppressive therapy?
Yeah.
Any
So regarding follow-up, yes, I tell them that they be on follow-up for every 3 monthly for the first 2 years, and then afterwards 6 monthly, and after 5 years, yearly once. If it is ATA low risk, probably after a year itself, I tell them to come after 6 months, and then yearly once after 2 years. And I never had a problem. In fact, they'll be more than happy that they don't want to see my face very often.
Yes, that is true.
Just to add to the previous one, the resources with radioactive iodine that was mentioned. Just yesterday, we were discussing in the breast meeting that there are a lot more nuclear medicine centers that have opened up in the last 5 or 6 years. So maybe the patient will have to travel an hour or two to go to a center, but most of them are willing to travel that time for one single dose of radioactive iodine at least. So I think we are seeing significant progress. I'm sure in the time to come, we will have more centers as well. So I think resource constraint is slowly becoming no resource. I would still say low resource, but not no resource at all
I
anymore.
agree with you. I agree with you.
That's
But actually, the previous question was something different. The patient had a local recurrence, and that too waiting for this thing. That's all. And probably the wait period might have been at least 3 weeks or 4 weeks. That's what, if I'm not wrong. That's what
yes,
my
that's
understanding
correct.
is.
Yes, that's true.
Anyway, actually saying the pathology has to be reviewed in that case because usually a DTC won't recur so fast. Either it has to be a differentiated high grade or it has to be an anaplastic. Apart from that, even 4A differentiated thyroid carcinomas do not recur in the neck so fast. And if it is the case scenario, I think RA also will not work
Or a residual.
for a
Definitely,
resident.
R2 resection, and it has to be reviewed. The histology needs to be reviewed. Also, Dr. Smith, about what you were saying about the follow-up of RAI patients, that now it's no more a scarce resource for us. It's also because we've stopped sending patients for low-risk patients for radioactive iodine. I think that also makes
Yes, yes. A
a
lot
lot.
of them do not get radioactive iodine anymore. Yeah.
Right. So moving on to our last segment, hits and misses. So I want Dr. Spandana to start. What, according to you, are the three hits among the guidelines that can readily be applied to our setup from the ATA guidelines?
One of them would be, as already has been discussed, avoiding prophylactic CCLND in all patients.
Right.
Uh, uh, Less routine radioactive iodine in low-risk patients. That would be another. And
True.
avoidance of oversuppression of TSH in case of low-risk patients. That would be the third, according to me.
Anybody would like to add any further ones to what Spandana has already said? Because I completely agree with her.
And we are moving from total to hemi. This is like one what I feel for myself. So that is one thing.
True. So then, Dr. Smita, what are the three misses among the guidelines that seem far-fetched for us for now?
No thyrogen, at least in the near future. No
Yes.
molecular testing. No active surveillance, at least from me. Unless and until I know clear-cut guidelines as to how to do an active surveillance properly. And no percutaneous ablation for malignancies yet.
There was also Professor Souza also actually mentioned regarding the new adjuvant use of tyrosine kinase inhibitors.
Yes, I think many of us are already using it
Right, right,
for unresectable tumors.
right. So I think my last question for the day would be, what three context-specific guidelines do you think we should incorporate with respect to our Indian scenario? And I would like Dr. Fareen, Dr. Sasi, and Dr. Roma ma'am to weigh in on this. Uh, my 2 cents for this would be the one that I just discussed, that new adjuvant use of TKIs should be included, at least for our patients, because we still have quite a lot of them who present to us in locally advanced stages. At least I see in my practice in a government setup. So, do you think we have any specific guidelines that we should be adding to our, which is not mentioned in the ATA, but we should be adding to our Indian scenario?
If I may add in, sorry.
Go ahead. Yes, please
Go
go
ahead,
ahead.
go ahead.
Maybe we can have a clear criteria for the general surgeons as to when to refer patients to an experienced or more capable surgeon.
I don't think that can be part of
They
guidelines,
not.
though.
They
Even if it is, I don't think they'll follow it.
first of all, they don't even.
Read it, is
With
it?
due respect, they don't exactly. I don't want to mention them, but yes, they are
No, I
not
think
bothered
that
about
part
it.
of active surveillance
How
needs to be specified. Active surveillance in Indian scenario needs to be discussed further. And because ablation is coming up in a big way, we need guidelines specifically made for ablations as well, as to which patients goes into ablation. And this needs to be uniform across societies, across surgical and radiological societies.
So basically, I think radiological, because we are not attending their meetings, radiological societies. What they are following is, what I have seen, they're doing biopsy before ablation of thyroid nodules. Even a like 1 centimeter nodule, they're
Yeah.
doing biopsy rather than cytology. So
Yes.
I don't know what they are planning in their societies, whether that is the guideline that they are following. So basically, if we keep that in our hands only, then we'll be able to propagate, because we'll be choosing surgery or ablation. So we can justify, because we'll be favoring both procedures in the right way. Otherwise,
So
they
the
depend on.
ablations by radiologists has come in a big way in a lot of places already.
Yes.
So I
Yes.
don't think it can be taken over by the surgeon as such, but working in unison, maybe going to their meetings and calling them to our meetings probably will do good to the patient eventually, and we will have a
That is
uniform
what I
guidelines
think.
that can be followed.
Uh, yeah, if I may add something, Sarah.
Yes, sir, please.
Yeah, so like for your question, context specific guidelines, what I think should be must in our guideline is that any patient with thyroid nodule should be evaluated by an expert radiologist, an expert cytologist, an expert thyroid cancer specialist, whether endocrine surgeon, thyroid surgeon, or endocrinologist who is expert in thyroid cancer. Then only patient should be advised that he or she should like not undergo any treatment, because the biggest problem which we face, I think majority of us, we see that many patients will have advanced thyroid cancer, and they would have come in contact with healthcare setup sometime, and many of them would have undergone ultrasound and FNAC also, and based on those, they would have been advised that it is nothing, don't worry about it. So I at least see 4 to 5 patients each month, which present to us with bone mets or lung mets, something like that. So that is very important. That is one of the most important things that I think uh, our guidelines should have.
And Santos, I would like to make a comment here that most of these patients have been advised this by endocrinologists or physicians rather than surgeons, to be honest. I don't know if you've had the same
Yes,
experience, but
yes. Totally agree. Totally agree. So that is why we have to make a recommendation that patient should have been evaluated by an expert radiologist and expert
Yeah,
cytopathologist.
expert is
But
the key there, I think. The expert endocrinologist still differs ablation even today. I have seen a very senior endocrinologist in the region who are against ablation. So I think that experience or expertise matters there.
yes, yes. So that is why it is important, right? I have seen very senior endocrinologists still prescribing thyroxine for thyroid nodule treatment. So obviously we cannot control that. But
I also feel that because we are also doing breast surgeries and we keep doing breast cancer awareness programs. Why don't we do thyroid nodule awareness or thyroid cancer awareness programs where we tell the patients that if you have a nodule, these are the tests that you need to go, because they are not aware. They are being advised by different physicians about different treatment modalities, and they don't come to us because we are always their referral point. We are not their primary point. So I think thyroid nodule awareness is also something that we should be focusing on a lot if we want them to come to us first.
But then that would lead to a lot of screening.
No, if they have a visible nodule.
You can control that.
Yeah. Okay, I
Yeah, I'm
think
not sure the awareness bit will help much because I mean the same way we see in breast, they go to all sorts of people. So I think yeah, probably going to a good person is an advantage for them. But I think working in association with other specialties is very, very important, because only when you work as a team is when you can make them understand this is guidelines and this is the difficulty we are facing. So if you do an ablation unnecessarily and then the patient lands up in surgery, this is a difficulty we are facing. Only when we discuss in forums is when they know that this is the problem.
right, that's true.
So yeah.
So I think we've had a very good discussion. Thank you to all the panelists. And thank you, a special thank you to Sanjay sir for making us come on this platform and discuss the challenges that we face on a daily basis. I think by far all of us have said the same thing, that this change is the only constant and we need to be adaptable to it. And we need to always have a vision for change. So thank you all so much. Sanjay sir, over to you.
yes, thank you, Sarah. Thank you, everyone. Roma ma'am, Smita, Sasi, Farheen, and sorry if I forgot someone. So thank you, everyone, for joining. So see you soon in some other activity.
Thank you. Thank you,
Good
sir.
night. Good
Good
night.
Thank
night.
you so much.
Good night.
Yeah.
Thank
Good
you,
night.
sir.